So today we're gonna talk a little bit about some basics of neuroanesthesia, and this is recorded, so we'll allow people to watch it afterward. So, kind of first thing first, just like most of anesthesia practice, we rely heavily on basic science such as physiology. So the uh, structure today will be kind of going through the physiology, pathophysiology, focus on intracranial problems, and moving on to pharmacology. And that will probably give us enough tool to handle most situations. So normal brain physiology, the important things to remember are brain has very minimum oxygen and energy substrate storage, so they don't tolerate ischemia very well. That's why we tend to be kind of nervous when they are hypotensive, or if they have intracranial hypertension that cut off their blood supply, and that would cause irreversible damage in a unit of minute. So that's kind of why we tend to be a little bit more cautious on anesthetizing patients with severe intracranial problems. The other thing to keep in mind is brain has very strong flow metabolism coupling. What this means is wherever it is metabolically active, the brain will auto-regulate to kind of shunt blood towards that specific region. And that is kind of the reason we can do functional MRI and PET-CT and stuff like that on brain to kind of know which part of the brain works with certain cognitive tests, emotion, those kind of things. And this is important because that's kind of related to the anesthetic drugs' impact on intracranial pressure. So going to kind of the major thing about supplying the oxygen and glucose, those kind of things, it's very important for body to supply blood flow, and the cerebral blood flow is determined by the perfusion pressure and vascular resistance. That's pretty straightforward. We kind of use this as like a hydraulic analogy or electric analogy, where you have the driving pressure, you have the resistance that's impeding the pressure, and the outcome is the flow. So if you have high pressure with the same amount of resistance, you will have higher flow. Vice versa. If you have the same pressure with a lot of resistance, then you'll have lower flow. So you can see we don't necessarily change the vascular resistance. Well, we technically couldn't, but what we want to maintain a lot of times is the cerebral perfusion pressure, which is the difference between the mean arterial pressure minus the intracranial pressure or central venous pressure, whichever is higher. So the idea is pretty easy, it's straightforward. You have upstream pressure and downstream pressure. Downstream pressure is determined by whichever is higher, whether that's intracranial pressure or central venous pressure. So why is this equation important? It is because that when the intracranial pressure increases, if the body want to maintain the same amount of perfusion pressure, then there's no other way other than increase the mean arterial pressure to maintain that gradient, so the blood can be squeezed into the skull and supply blood. Okay, so that kind of extends to what we normally see and worried about intracranial pressure. So very popular and commonly used idea of intracranial pressure is what's called Monroe-Kelly doctrine, and the pressure of intracranial space is determined by the volume of three things, and most of those are brain tissue, that's 80%, and the other two things are Ooh, it does not allow me to go back. Oh no, well, the other two things are blood and CSF. And you can see the graph on the last slide that shows you have some buffer and compensation that body normally has to tolerate increase in the volume of whichever component that's going to increase, whether you have a tumor or you have hemorrhage or hydrocephalus. Body has some way to compensate for that, but that's kind of a critical point. When the compensation is exhausted, then the pressure will spike quickly. So this is a graph to show what I mean. So on the top, you have normal ICP with normal states, and the ratio of these things are kind of exaggerated. There is the brain tissue and the blood and the CSF. When you started to have a brain tumor, what it does is it squeezes out the CSF and the venous volume, because the venous is the majority of the blood volume. So that would be the compensated state. So this is when the body is in compensatory state, and if the mass get bigger and bigger, eventually you're gonna exhaust how much extra CSF or venous volume you can squeeze out, then you will become decompensated and have a spike in the intracranial pressure. So we probably see, I don't know, most of our patients probably in the compensated state. Once in a while you see one that's in a decompensated state, or if you have a craniotomy, you'll probably go from compensated to decompensated, depends on the case and what goes with the surgery. So factors that affect the cerebral blood flow, again, this is kind of focusing on the body can only quickly adjust things in the skull, and one thing we manipulate more is the blood volume, and mostly the venous blood volume. The CSF volume we can manipulate, but not as much, and it kind of takes a little longer. The CSF volume is usually adjusted by like medication for hydrocephalus, like diuretics, and medication that decrease the CSF secretion. So here are the things that affects the blood flow, because the blood flow affects the blood volume. Things like cerebral metabolic rate. This is kind of linked back to, we mentioned the brain has a strong flow metabolism coupling. So if the brain is very active, it's gonna demand more blood flow and increase blood volume. But if you sedate them or anesthetize them, then they will decrease their metabolic rate, which will decrease the cerebral blood flow and subsequently cerebral blood volume. So that's one thing. The other things that can change the metabolic rate are the temperature. If you cool them down, then you will decrease the metabolic rate. Or if you have like seizure or perioperative arousal, they can have a spike in the metabolic rate, and then that could increase blood flow. The other things that we are familiar with is the CO2. If you have high CO2, it can cause vasodilation and increase blood flow and blood volume. And if you have low CO2, then you can decrease the blood flow and decrease the blood volume. O2 also has somewhat similar effects. If you have low O2, you can increase blood flow because the body needs it, and vice versa. But in the physiologic range, the O2 doesn't change that much, unless you're like severely hypoxemic. Otherwise, it doesn't change that much. Drugs that can directly cause vasodilation or vasoconstriction, like anesthetic, especially inhalant, vasodilator or vasopressors. We'll talk about it a little bit later. The rest is a little bit more like like autoregulation from myogenic mechanism. Myogenic means when the pressure goes up, the blood vessel being stretched, and you want to constrict to counteract the hypertension to protect the organ from high blood pressure. When the blood pressure is low, the myogenic mechanism will dilate the blood vessel to allow to maintain the blood flow. So it's kind of like basically autoregulation. The relevance of this is we want to pick the drugs that preserve the autoregulation, and we want to guesstimate if the patients still can't autoregulate their blood flow. So that's where it comes in. We'll talk about it a little bit in the inhalants section. The rest is we don't really touch on this much, like the blood viscosity, if they're anemic or not, those can change, but we don't really play with that too much since there are more reason to adjust those things than mess with the cerebral blood flow. Okay, so this is what we kind of talk about with the graph about CO2 and O2. CO2 you can see is kind of linear. This is the 50, this is 0, and this graph, this line probably goes here like plateau somewhat. You can't really say the number kind of plateau. You can't really get 0 CO2 unless you're dead. But you can see in the physiologic range is more or less linear, and the O2 within the normal range, like let's say here is probably 100, here is probably 80. Like you don't really change that much unless you're like less than 50. So we don't really care about this unless like some strange situation. For the mean arterial pressure, you can see it's plateau here. This is the autoregulation. The pressure and the blood flow are disconnected. The increase in pressure does not necessarily increase in blood flow, but it didn't have other parts. Like if you go really high, obviously, you can overcome the myogenic mechanism. But if it's really low, then obviously you can have problem supplying blood flow. That's out of the autoregulatory zone. So autoregulation is between here, and that's why we tend to keep the mean arterial pressure above 60. The brain has a little bit different cutoff about where it started to drop, where the flow became pressure dependent. But 60 is higher. It's for the kidney, most people would say, and that's enough to perfuse the brain. But we have seen dogs and cats having mean arterial pressure 40, 50 that still wake up like nothing. That's because the brain doesn't need as high of perfusion pressure to get blood. Okay, and the next important thing obviously would be signs of intracranial hypertension, because that's the thing we would work with everything we have to avoid. So if they are awake, one major thing would be altered mentation. So I'm always very careful about how the patient look coming for brain MRI. If they look dull and jumpy, that's kind of concerning. For sure. Pupil size, if they have intracranial hypertension, they can have asymmetrical like anisocoria. They can have blown pupil size. They can have very constricted pupil size. Sometimes you can see that under anesthesia, but a lot of times the opioids and anticholinergic can change things. So that's kind of not 100% accurate, but that's something for you to keep an eye on. POR, gagging reflex, respiratory pattern, those are the things. By the time we know this is wrong, it's probably during recovery, and that's pretty bad. So we don't really use that. But again, if it comes a patient that looks really dull, those are the things you can use to confirm if the intracranial pressures are bad. Then you might need to be very careful. Obviously, if they have a head trauma, you need to consider the influences from shock. If they're not perfusing the brain, obviously they'll be dull. Doesn't need to be having an intracranial hypertension. The eye ocular test, that pupil size or POR, obviously can be affected by ocular injury. Pain can change the pupil size. Thoracic trauma can change the respiratory pattern. Stress can change the respiratory pattern. The gagging reflex obviously can be changed if they have like a lot of sedative or medication. It's obviously not common to measure the ICP. As far as I know, nobody does this other than for research. And I don't know anyone does this for clinical patient, and that I have ever heard of. But nowadays, people like to use ultrasound on everything. The optic nerve may be a window to monitor ICP indirectly because the optic nerve is a direct extension of the brain, and if the pressure is high in there, the optic nerve will be wider. There are studies on this, but for most of our patients, we're either draped in or in a magnet, so we're not going to be using this much. It's probably more useful for ICU. Okay, a very common thing we talk about is cushion reflex. We're just going to go through it again. So when the brainstem get compressed from intracranial hypertension, it can cause ischemia and accumulation of CO2. That will activate the sympathetic system, and that will increase the hypertension. Like we talked about, the body tries to maintain the difference between the upstream pressure and downstream pressure. When the downstream pressure goes up, body will try to increase the upstream pressure by causing systemic hypertension. When the body does that, it will still activate the barrel reflex and cause bradycardia. That's kind of the classic cushion reflex. But I want to kind of show you a couple of older study that shows patient doesn't always show bradycardia, but they almost always show hypertension. So on the top is the X is always ICP, the intracranial pressure. The top is the heart rate changes. The bottom is the blood pressure changes. You can see that on the the normal is somewhere around 10-20. So at the beginning, you don't see a whole lot of difference. And some of the patients actually a lot of patients in this study actually end up showing tachycardia, not bradycardia. But almost all of them started to show hypertension once you go beyond 50. So to me, it's very important to know that heart rate doesn't always tell you what's happening, but hypertension makes sense because the body tries to maintain the difference between upstream and downstream pressure, right? So hypertension makes sense. So this comes to, I've talked to some of you that I get a little paranoid when you anesthetize in a brain case that has too good a blood pressure. Say cats, almost all the cats like to be hypertensive. But if you have a cat that just like very stable in the magnets, and you got a direct blood pressure, the blood pressure is like mean of 70, 80, that makes me worried. If you have a white fluffy dog, small dog, that tend to almost always hypertensive. If you got hypertension, then you gotta be a little careful. Okay, so what can we do when we have intracranial hypertension? One is to elevate the head, so you can facilitate the venous return. You elevate it by 15 to 30 degrees. It would be if you have not measured what 15 to 30 degrees look like, you'll be surprised how steep that is. So putting a small towel like a pillow not gonna do anything. So you gotta really elevate the head to use the gravity. CO2, obviously we want to avoid hypercapnia, high CO2, which can cause vasodilation, but we also want to avoid prolonged hypocapnia. This is kind of, I found it a lot of times hard for people to understand why this is a problem. So if we think back on what we're trying to do, so we're trying to maintain cerebral perfusion pressure to maintain cerebral perfusion flow. Our goal is to perfuse the brain, right? We want the flow. So when we have increased intracranial pressure, we decrease the CO2 to cause vasoconstriction and decrease the cerebral blood volume, and hoping that will decrease the intracranial pressure. So we are basically trying to lower the downstream pressure to maintain the perfusion pressure. However, the way we do it is to cause vasoconstriction, which in itself inherently can decrease blood flow. And that is counterproductive to our original goal, which is maintaining the flow. That's why I don't keep my CO2 low universally for my brain cases. I use hyperventilation and hypocapnia as emergency treatment because of that. Because again, if you cause low CO2 vasoconstriction and decrease blood volume and decrease ICP, you are also decreasing the blood flow to some degree. And there's no way for us to know which one is winning. Are you having an overall increase in flow or overall decrease in flow? So I tend not to use this as a baseline to keep the blood flow lower. So the other reason I don't use hypocapnia, low CO2, as a kind of a universal whenever I anesthetize them is because when you apply a low CO2 from hyperventilation for a period of time, when you take that away, you will have a rebound intracranial hypertension risk. So that's why I don't keep my patients CO2 below normal range, which is 35. I know previously we accustomed to keep it 32, 35, but to me, somewhere around 40 is perfectly fine. That's something I think good to be on the same page about. Other than that, hyperosmolar therapy is the only thing that can help us reduce the volume of the brain tissue or the mass, whichever kind of mass that is. We have two options. We have mannitol and hypertonic. There's no clinically significant difference. You can look at 10 studies that will probably give you 50-50 on which one is better. And you want to use it when indicated. You don't want to prophylactically use it because there are side effects from it, and you will lose your efficacy once it accumulates. So we don't universally give a mannitol before the brain MRI because of this. Side effects, you can have diuresis, hypovolemia, hypotension. You can have acid-base changes, especially with hypertonic saline. You can have delusional anemia. You can have AKI, electrolyte changes. So again, we use it when we need it, so side effects not really a concern when we have to use it. But those are the things you want to keep in mind, that we don't just use it for no reason. Okay, moving on to medication. Any questions so far? No? Okay, moving on to medication, anesthetics. Overall, we have injectable and inhalants. Most of the injectables will decrease the metabolic rate and decrease the cerebral blood flow. That's pretty intuitive because you sedate them, the brain cells are not active, they need less blood flow. Easy. And when you look at the drugs like dexmedetomidine, midazolam, diazepam, opioids, propofol, they all do pretty good things, other than ketamine is the exception. Ketamine actually increases metabolic rate in some area of the brain, especially like limbic system. So that's why people tend to be a little bit careful. But if you look at the dose on this chart, again, this is not dogs and cats data. This is 0.15 milligram per kilogram per minute. So that's 150 microgram per kilogram per minute. And that is very high dose. We don't normally use this kind of dose. But we do give a bolus dose, so we gotta be a little bit careful on those things. But the bolus dose we give still not really reaching the dose that has been concerning for human patients. Additionally, it has been found that if the patient is already anesthetized from something else, such as inhalants, benzodiazepines, propofol, whatever that is, the effect of ketamine is attenuated. It doesn't cause a significant change. Also, just by using itself, it's not that drastic change. But you will hear people have like, oh, ketamine is contraindicated. Yes, it's contraindicated to use it by itself. You don't want to anesthetize a patient just with ketamine if they have intracranial disease, but it's not always necessarily contraindicated with the dose we use for inhalant dose reduction or analgesia. That's probably not going to hit that high of the dose. Okay, so jumping into inhalant. Inhalant is a vasodilator. So vasodilation causes increasing blood flow, increasing blood volume, increasing intracranial pressure. That's a concern. But it's an anesthetic, so it decreases metabolic rate, decreases blood flow, decreases blood volume. So essentially, the inhalants kind of interesting. You need to balance this kind of things. This slides to show that it is very important to keep your inhalant dose low. So the normal is the dashed black line, and going to the left is higher and higher dose of inhalant. You can see low dose inhalant, you kind of still have that auto-regulation, but as you go up, you lose that auto-regulation, right? So it's very important to me when we use inhalants in brain cases, we keep the MAC below 1. We have talked about this neuroscience, and I've said that the standard answer, one of three standard answer for anesthesia is turn down your inhalant. This is one of the reasons. And this is the one I mentioned. You got vasodilation versus decreased metabolic rate. So this graph, if you look at the metabolic rate, is the yellow one. It decreases and kind of plateau around 0.5. So you can see the cerebral blood flow actually decreases until it hits 0.5, but it goes back up. Because once you go above 0.5, your vasodilation started to kick in and then win. But once you go above 1, it definitely trumps the decreased metabolic rate because it doesn't decrease further here. So this is another reason keep it less than 1 MAC is very important. And actually, towards 0.5 would be even better, right? Because it's kind of still in there. Is it better to go even lower? Well, kind of depends. If the patient is hypotensive, this curve will obviously be different, right? So you kind of have to think about all those things. Okay. So among inhalants, halothane is the worst. So the yellow bar is the cerebral blood flow. The blue bar is the metabolic rate. You can see they are anesthetic. The metabolic rate is going to drop. The cerebral blood flow from halothane, which we don't use anymore, increased a lot. Despite the decreased metabolic rate, the vasodilation is bad. So don't use halothane. You can't, even if you want to nowadays. So the two we have is ISO and SIVO. You can see it's not that big a difference. Slightly better with SIVO. It doesn't increase the blood flow as much, but ISO is not that far off. Which is why I don't really worry too much about between ISO and SIVO, but technically SIVO is slightly better, and people have done research shown that SIVO technically preserves the auto-regulation stuff a little better as well. So technically it's a little better. How much better? It probably matters for a patient that's kind of on the edge of decompensating, but probably not enough to be a universal situation. But if you have a really sick brain disease patient and you want to use inhalant, SIVO will probably be the better one. So this is kind of we're going to wrap up pretty soon. This is to show you that we've been talking about cerebral blood flow. It is because it's much easier to measure the flow compared to measure the volume. It's really hard to measure the blood volume. But you can see that cerebral blood flow changed by 50%, only changed the blood volume by 20%. And the volume is what changed the intracranial pressure. So that's another reason I think we're talking about all this kind of splitting hair thing. When you translate to clinical management is not as drastic difference. We can make us feel better by, oh, I'm doing everything I can, but how much more it is to me is sometimes questionable. One of the reasons is we have a lot of cerebral blood flow data, but we don't have a lot of cerebral blood volume data, and they are not one-to-one. So all the differences, if you think back that SIVO versus ISO difference so little, and you take another discount, reflect back to the blood volume, and the clinical differences probably is even less. So comparing the propofol to ISO, I know we used to do much more propofol TIVA, and I have to say that I don't know if that make a huge difference. If you look at this, the cerebral blood flow between propofol and ISO, that's a big difference, right? The blue one. But if you look at the yellow one, the blood volume, it's not a big a difference, and that's kind of because that is because the last slide showing that the flow changes more, but the volume is not as big of difference. Okay, so those are the anesthetics. Any questions so far? So I think the big takeaway is that injectable is in theory better. So if I have a very sick patient that has terrible brain disease, yes, propofol TIVA is technically still better. Behind that, technically is SIVO. Behind that is technically ISO. But if you're not familiar with using TIVA, or I just personally don't like TIVA in cats with propofol. Just it takes forever to wake up, and we're not really set up to have proper post-op monitoring if it takes a long time to wake up. And we tend to do a craniotomy late in the afternoon. Latest, like they will try to recover like 5, 6, 7 when everybody's leaving. That just to me makes it pretty hard to use propofol TIVA. That could take about an hour to activate, or just live in ICU, and now no one is watching as close as it needs to be, those kind of situations. So I've been using more inhalants, but use a lot of injectable to keep my MEC between 0.5 to 1. So that's why I've been doing what I've been doing. Okay, so the last slide is to show you vasoactive agent. So you have alpha agonist, so that's like a phenylephrine. Norepinephrine is mostly alpha with some beta. You can see alpha doesn't change much, right? The plus is go up, minus is go down. This is cerebral blood flow, this is cerebral metabolic rate. We probably care about the blood flow a little more. We didn't touch base more about like a little bit complicated details about it's actually a balance between the metabolic rate and the blood flow. You actually want to keep a balance. You want to have if you lower the blood flow without lowering the metabolic rates, you can cause potential ischemia, right? Because if the cell is still active, you use some drug to decrease the blood flow, you can cause ischemia risk. So minus is decrease, plus is increase. So alpha 1 doesn't change much. Great, right? So that's what we want. It's neutral. We are only manipulating the blood pressure without changing the cerebral hemodynamic too much. Alpha 2 actually decrease. Alpha 2 is dexmedetomidine. Understandable. Beta, dobutamine, or mid-dose or low-dose dopamine actually increase blood flow. So you can actually increase intracranial pressure from that, especially if the blood-brain barrier is open, meaning that if you have intracranial pathology, then you can really increase the cerebral blood flow. So high-dose dopamine, you might decrease it when you get a lot of alpha, but in the dose that's mid to low, you can actually increase blood flow. So not great. Norepinephrine is kind of 0 minus 0 plus, so good. Even if the blood-brain barrier is open, it's still 1 plus, right? So not bad. Epinephrine has more beta, so it's kind of proportionally higher, so you got more. So to me, technically, norepinephrine is better. Price of choice with intracranial disease patients. And I've been thinking about asking us to make a default for presses to be the norepinephrine instead of dopamine. just across the board for all the cases, because when they're anesthetized, they are mostly vasodilated. So really, the norepinephrine is the one that's more effective. And last year or a year before, Virginia Tech published a study showing that dogs, obviously with inhalants, hypotension respond to norepi better. So for the case we have, we should probably just universally switch to norepinephrine instead of dopamine when we have a pressure on the machine. Okay, that's it. So takeaway, know what control intracranial pressure and why we care about intracranial pressure. I can send out another quiz. I know you guys love it. So again, why we care about intracranial pressure, what controls it, and what to look out for when it's high. And for the drugs, be familiar why we do not want to increase inhalant too high, and how we balance the needs between theoretical and clinical benefits between total intravenous anesthesia versus inhalant anesthesia. Any questions so far? Otherwise, that's it.
Other than in cats, in dogs, is there any sort of downside to doing a propofol tiva if you suspect maybe ICV?
Yeah, I mean, we don't have a lot of data on each species, but I think we know propofol tiva is technically better for decreasing the blood flow, decreasing the blood volume, decreasing the metabolic rate, better autoregulation, all those things. Cats just doesn't metabolize either propofol or afoxolone very well. It just takes a long time for them to recover. Not a bad thing. If you're a human, no one's gonna try to wake you up after craniotomy. But limited by our resource, I would love to, we do this early enough. We wake up as long as we need, watch them closely, and leave them be. But a lot of times we don't have neurologists spare whole day and do the craniotomy first in the morning. We tend to still do it early afternoon or late morning. So that's, to me, it's still a constraint. Dogs, they tend to be fine. It still takes a long time little longer to wake up from TIVA, but just not as bad as cats. Is that what you were asking?
Yeah, just can we consider that a little bit more than if we're working up a case? And
we can. I mean, it just case selection would be the major thing to me. Yeah, if there's a case that would be make or break with TIVA versus inhalants, then yeah, we'll use TIVA. Sure. You can always argue if there's that big a difference, how likely they'll survive is another thing. Like, if they cannot survive the difference between TIVA versus inhalant, would they really survive anyway? That's a pessimistic thinking, but if we want to do everything we know, then yeah, some patients will benefit from TIVA. I don't know if it's hard for me to notice if I have higher mortality for my neuro cases compared to other people. But I feel like the patient kind of still is the major determining factor about prognosis. As long as we do the basics well, like prevent hypotension, all those kind of things, to me it's still, if not more important, just as important to pick between TIVA or inhalants. If we are not able to mentally process running TIVA, then I'd rather the person running the anesthesia use inhalants, which is more comfortable and familiar with. All right, thanks.